PFC. During the webinar, you can send questions through the presentation in the Q&A feature located at the bottom of your screen. And as a thank you for being here tonight, we are offering a $99 new patient assessment for patients that don't have insurance coverage or accepted insurance coverage. That said, Dr. Strug, you have the floor.
Okay, thank you for the intro and welcome everybody. Thank you for joining us. I know that it's a weekday, so it's probably pretty busy during the week, so we appreciate you joining us. I'm gonna advance the slide here. So first, just want to give a little bit of a background of myself. So I'm a board certified OBGYN and I am a fertility specialist or REI. And so we do additional training outside of being an OBGYN in fertility. And I joined the practice at Pacific Fertility Center a little bit over a year ago, and have really enjoyed being here in that short time frame. So just to kind of give a little bit of an overview of our presentation tonight. First, we're going to be discussing a little bit about fertility in general. We'll discuss some fertility treatments, what to expect as far as success rates, and we'll open the floor to questions. So first, a little bit of a background. So this pie chart sort of breaks down the most common causes of infertility, and I usually break it up into about a third. So a third of the time, and you have to understand that this is also referring to patients who have a male and a female partner. So there's other considerations outside of that. But in this case, female factors contribute to about a third of cases, male factors are about a third. And then about a third of the time after a complete and thorough workup, we don't find a cause for infertility, and that's called unexplained infertility. And just because we don't necessarily find a cause doesn't mean that there aren't any treatment options available to those patients. And we'll discuss that a little bit further in detail. Now, this kind of breaks down for you all of these the like kind of breakdown of each of the causes, and then within those, what are the actual issues that we sometimes will see that contribute to infertility. So for female factor infertility, oftentimes it's an age or ovarian problem that's contributing to fertility issues, ovulation problems or conditions like PCOS, polycystic ovary syndrome, where patients are not releasing an egg predictably, so it can be really challenging to time intercourse or to figure out when to actually try and get pregnant. Other conditions that are maybe a little bit less common would be things related to blocked fallopian tubes. So the sperm and the egg have to meet each other in the fallopian tubes. And so if there's any blockages due to various reasons, that could be a reason why people have trouble getting pregnant. There's also some uterine factors. And then endometriosis is a very prevalent condition, and about half of patients that have endometriosis have some level of subfertility. There's also a lot of other factors like health conditions that people may have, like autoimmune type conditions that can affect fertility, or endocrine type conditions, thyroid problems, those types of things. And so we evaluate these things when we're, meeting you for the first time. We want to get a really global view of your health and those types of things which may be contributing to fertility issues. And lifestyle is also another factor. Things like smoking can affect fertility as well. So male factors, similarly, we're looking at age as a factor, sperm issues, so sperm production or motility, the movements of the sperm, all these things can affect whether sperm can fertilize an egg. And so up to a third of cases, it's due to sperm issues. And similarly, we're looking at metabolic, endocrine, health type of factors that are contributing to fertility issues. And then we also look at lifestyle factors as well. So these are some of those problems or issues that I mentioned before, and this is the type of testing that we will oftentimes perform. Not standard on everybody, but for instance, like we don't offer a laparoscopy, which is a type of surgery to treat endometriosis. We generally, go based off of individual need. But we do tend to be pretty comprehensive in our initial evaluation in patients. And so it usually starts with getting a really detailed history of your background, your medical concerns, things that you've experienced in life. And then we talk about how are you timing intercourse and having intercourse? Are there issues with that? Are there issues with potentially releasing eggs reliably, looking at cycles? So we actually gauge a lot of fertility issues based solely on just history. But then after that, we generally will also want to get some blood work, and we tend to look at a lot of different factors all at once. And part of that is because we don't want to go down a road of saying we think that this is the issue when there's up to 10% of the time there's combined issues where there's male factors and there's female factors that contribute to fertility issues. And so we tend to be pretty comprehensive and broad in our testing up front because you want all of the information to make the best decision about what to do next as far as treatments. So blood work usually for any involved partner. And then for male partners, we recommend a semen analysis where we're checking sperm counts and motility and all of those things. And then for female partners, usually we're doing an ultrasound and looking at egg counts, and we'll discuss a little bit more about that as well as it pertains to fertility and evaluation. One of the key factors and the biggest predictor of fertility is age, and it tends to be primarily age of eggs because unfortunately, the way that ovaries are exist, you're born with all of the eggs that you'll ever have, and as you age, it's a part of the normal aging process that the eggs will decline in number and also in how they create embryos and the health of the embryos that they create that could result in a pregnancy. And so this is just a fairly old study at this point, but it still remains true. But the age of the eggs are going to be the biggest predictor of fertility, and we know that over the age of over the age of 40, natural conception rates in each month are less than 5%, and that's largely due to ovaries and how they work. So ovarian reserve is a term we use to say reproductive potential, and that's specifically looking at the number of eggs and the quality of the eggs. And these things are both factors that influence one's ability to get pregnant. I mentioned this before, but I think that it's important for this point to really hit home that you're born with a certain number of follicles, which are just fluid filled pockets in the ovaries that contain eggs. And as one ages, the number of those follicles will decline. And so the other thing is that the proportion of abnormal or poor quality eggs will increase as one ages. And these things start to peak in your mid 30s and certainly by the time you reach your 40s. And this is a large draw for why many people will elect to pursue things like fertility preservation or egg freezing, embryo freezing, with the goal to preserve your eggs at a time when there's more of them, when they have higher efficiencies and they're better quality. You know, I so that's one of the reasons why people will consider doing those things. This also shows that not only are pregnancy rates lower as one ages, we also see that there's higher rates of miscarriages. And so there's higher incidence of pregnancy losses. And these are largely due to chromosomal imbalances or imbalances in the genetics of the embryos. And this is most likely abnormal embryos that are associated with age are less likely to implant, which is infertility, or if they do implant, they're not healthy enough to continue to keep growing, and that can result in the pregnancy not growing, and that's when a miscarriage happens. This shows you visually what chromosomes look like. So chromosomes are contain all of the genetic material, and most people have 46 chromosomes or two copies of each chromosome, and that's one from the egg and one from the sperm. And we know that as one ages, there's a higher incidence of aneuploidy, where there can be extra or missing pieces of chromosomes. This is showing an extra chromosome 21, which is also known as Down syndrome. This is really one of the only circumstances where having an extra chromosome is compatible with life. And in most cases, when there's extra or missing chromosomes, it's more likely that the pregnancy will either stop growing or result in a miscarriage. So when we're doing your testing up front, we're evaluating the ovarian reserve by performing two tests to assess the quantity of eggs. And so one of those is a blood test that's called an anti-Müllerian hormone, and that hormone correlates roughly with the egg supply. And antral follicle count is a special type of ultrasound where we're looking very closely at your ovaries and counting the number of fluid-filled pockets, which you'll see in the next slide what those look like. But those numbers for the count of the follicles and the blood test both help us to predict what the number of eggs may be. And this ultrasound is showing an ovary. I typically describe to my patients that the ovaries look sort of like flattened chocolate chip cookies on an ultrasound, for lack of a better description. But these little dark black circles, fluid appears black on an ultrasound, and so these fluid-filled pockets are actually called follicles, and these contain eggs. So we can't see eggs on an ultrasound because they're microscopic, but we can see the fluid that surrounds them. And the antral follicles are the pool of eggs that are recruited each month. And I think it's important to understand how eggs work. So generally, there's a pool of eggs that are recruited in each menstrual cycle at the beginning of the month. So that's what this little pool, like each of these little circles, represents one follicle. And each of those follicles have the potential to grow into an egg that could result in a pregnancy. And typically, just one of these eggs will grow in that month, and these other ones will just disintegrate and not continue to grow. And that's why people lose eggs, even though you're only releasing one egg each month, you're actually losing multiple eggs in each cycle in this antral follicle count. The other that's important to make about antral follicles is that we can consider this sort of the ceiling of how the ovaries may respond. If people do fertility treatments, the most eggs that we could likely expect within range is this number of follicles. So this helps us to assess what types of treatments patients may benefit from. So I mentioned those two tests to predict quantity. So the blood test AMH, or anti-Müllerian hormone, and the follicle count. Now, for predicting quality, age is really the best predictor because there have been lots of studies where they've actually looked at the embryos that are created from people at different ages, and we find that that directly correlates with one's age, the quality of the embryo, or the quote unquote health of a embryo that can result in a pregnancy. Diminished ovarian reserve is something that we commonly see. So as I mentioned, patients who have ovaries, the number of eggs will decline over time in a predictable fashion. But in some patients, we sometimes see that their egg numbers will decline more rapidly than others. And that really plays a really large role in what treatments we're able to consider. And many people will consider freezing eggs if they're younger in the scenario, or not having fertility issues, to try and preserve their fertility for the future. So let's discuss a little bit about what fertility treatments are available. And I think it's helpful to break down what the goals of infertility treatments are. One goal is that if we find a problem or an issue, let's say sperm counts are very, very low, or we see that you're not ovulating predictably, you go months without ovulating, or even just have longer cycles and we think there's concerns with ovulation, we can fix those sometimes with medications or with procedures like IVF. For instance, if the sperm counts are really low with IVF, we only need one sperm to be able to fertilize an egg. So that's how, advanced the technology is, that we can help fix these problems. Or let's say fallopian tubes are blocked. In that scenario, IVF is really the only option because we oftentimes, most cases, can't unblock the fallopian tubes. For ovulation problems, we can try medications to try and get the eggs to grow and release more predictably, to time intercourse, or use inseminations around that. So this is the first type of option for treating infertility. Is if we find an issue, let's fix it. Now, the other option for treating infertility, and remember back to earlier when I was saying that up to a third of patients have unexplained infertility, where we don't find an actual cause, then we're thinking, okay, so each month when you're trying to get pregnant, you grow one egg and you have intercourse, and a certain number of sperm reach that egg. And so we want to try and increase the chances of that being successful. So that means trying to get more than one egg to grow, and trying to get the sperm and the egg closer together, or more sperm closer to the egg. And so that's the overall concept, is that we're just increasing the number of chances in any given cycle. And there's different ways we do that. So one is where we give medications just to grow maybe 2 or 3 eggs in a month, along with performing an insemination where we're collecting sperm, placing them in the uterus closer to the egg. That's one approach. And then the other approach is IVF, where we grow lots of eggs, hopefully, and collect the eggs in the lab and create embryos in the lab. And there's some advantages and disadvantages to both options. So I welcome any questions, but I'm going to go through the different treatments, and I'm happy to answer any questions that people have about those treatments, and the pros and cons. So this is a breakdown of sort of the fertility treatment menu, I guess, for lack of a better word. But ovulation induction and insemination is one treatment. Another is in vitro fertilization. And then the last is third-party reproduction, where sometimes people consider using donor eggs or sperm or gestational carriers. So ovulation induction, the goal of this is to use fertility pills. Things like Clomid or Letrozole are the most common pills that we use. And this is to recruit an egg or multiple eggs to grow and release. So who's a candidate for this? The prime candidate is people who have ovulation problems like PCOS, where you're not growing an egg or releasing an egg. And so these medications help to fix that problem. Now, patients with unexplained infertility, or who are not ready for IVF for various reasons, may consider using this approach as well, because there have been studies that have shown that patients who have unexplained infertility do have higher pregnancy rates using a combination of these fertility pills and insemination, which I'm going to go into in the next slide, as compared to trying on their own. Okay. The timeline for this, usually, because of the pregnancy rates, what they are, and we'll discuss those as well, we know that it can take multiple attempts. So the odds are unfortunately such that it usually requires that you need to be willing to do like about 3 to 6 attempts of these types of treatments in order to see if there's an effect. And the effect sort of plateaus after 6 cycles, where there's not really much increase in your chances of getting pregnant if it hasn't worked by doing it 6 times. In IUI is most commonly referred to out there, is intrauterine insemination. So the goal of that is to just increase the number of sperm that can reach an egg. So when people have intercourse, there's a certain number of sperm, millions of sperm, that are released into the vagina, and a small fraction of those sperm are able to traverse the uterus, travel into the fallopian tube, and meet the egg in the tube. And so when we're performing inseminations, we're collecting more of the sperm, we're washing the sperm and prepping it to allow for more moving sperm to reach the egg by placing it directly inside the uterus. So candidates for this procedure: unexplained infertility, as I mentioned before, in combination with using a pill to induce 2 or 3 eggs maybe to grow. and patients who have slightly lower sperm counts. There are set thresholds of sperm numbers that we seek for this procedure to have an impact and improve chances of getting pregnant. If the sperm counts are very, very low, then we likely won't meet that threshold with doing inseminations alone. And in that circumstance, then we kind of have to consider IVF as the only option. So here's a breakdown of what the pregnancy rates that have been reported in research studies, and these are similar to what we see in our hands. So patients who have ovulation problems, as I mentioned before, are most likely to be benefiting from using this approach and this type of treatment because we are in that sense fixing a problem, which is that they're not releasing eggs predictably. And so treatments can result in a pregnancy rate of about 20 to 30% per cycle in patients who do this type of treatment and have ovulation problems. Patients with unexplained infertility, the pregnancy rates are between 5 and 10%, depending on age. Um, Now, the other consideration here is that what are the natural pregnancy rates? So I think it's valuable to kind of understand that. In patients who are infertile, so have been trying for 6 to 12 months, depending on your age, the pregnancy rates in any given month of trying are about 4%. So this does modestly increase the pregnancy rates. But in patients who have no fertility concerns, no infertility, the pregnancy rates in a natural cycle are about 15%. So it's bringing it closer. But the moral of the story is that fertility in general is really kind of an inefficient process. And so there is sort of only a certain point that you can reach by trying to maximize these things within your body, and that's what ovulation induction and insemination, everything is still happening within your body. You're growing the eggs in your body, and that embryo that's created, or potentially multiple embryos, can implant. And so the next option is IVF, where the goal is to grow multiple eggs and remove them from your body and bring them into a lab where we're able to control the circumstances a little bit more. We can help the sperm fertilize the egg by putting more sperm closer to the egg. We can also get more information about what types of issues may be going on because we can actually watch to see, are the eggs fertilizing? Is there a fertilization problem? Are the eggs not developing into an embryo? These types of things that when you're trying to get pregnant, within your body, we can't necessarily get that information. And so IVF has higher pregnancy rates because we are increasing the odds. We're taking, think of it kind of like rolling dice, and that's this concept of trying to have more chances in any given month. If you're rolling 10 dice or die, you're more likely to land on the number or a healthy embryo that's going to work and implant and result in a healthy pregnancy versus if you're trying with just one dice every month, then maybe your odds will be a little bit lower. And so people that may benefit from IVF, advancing age, and that's partially because we're able to perform genetic testing to help select embryos to place into the uterus and select an embryo that would be more likely to implant. Really low sperm counts, that would be an indication for IVF. Patients who have ovulation problems, but maybe they failed the treatments with using the oral pills, then in that scenario, IVF would be the next step. Endometriosis patients sometimes benefit from moving to IVF. And there, we see many patients who have maybe genetic disorders that run in their families, like breast cancer mutations or other conditions, that they want to actually do IVF specifically to screen their embryos to see if they have these conditions and select an embryo that doesn't have that condition. So we are sometimes able to do that depending on what the condition is and the circumstances. And lastly, IVF is also considered for fertility preservation, similar to what I was saying earlier about freezing eggs or freezing embryos. So the IVF process usually starts with taking injections that you self-administer, and we teach you how to do that. You watch videos, there's a class, And so those medications, the goal is to recruit multiple eggs to grow. So instead of growing one egg in that cycle, we're trying to grow lots of eggs. And then we perform an egg retrieval, which is a procedure to collect the eggs. And we'll go through that a little bit more in depth. And then we're able to inseminate the eggs or place the sperm with the eggs. Or in some cases, we perform ICSI, which is where we can help the sperm fertilize the egg by injecting it into the egg. And that's for people who have sperm problems that may prevent the sperm from being able to fertilize. Once we have embryos that grow from those fertilized eggs, we oftentimes will perform genetic testing or pre-implantation genetic testing for aneuploidy, looking at the balance of chromosomes. Similar to what we were discussing earlier, we look for embryos that have balanced chromosomes to select those embryos which are more likely to implant. And there's pros and cons to that treatment, but we can always discuss those in the future. As far as freezing anything that grows from that cycle, we then freeze the embryos. So they can be frozen for years and years. You may have heard on the news recently that somebody just recently was pregnant and delivered a 30-year-old embryo. So I don't necessarily recommend maintaining your embryos for 30 years, but it at least speaks to the fact that when we freeze embryos, it is safe, and there's a lot of data that embryos remain viable even despite freezing them, and it allows us to transfer the embryo when you're ready to do so. And so embryo transfer is the last step, which is a little bit less in depth than the process of growing the eggs and collecting the eggs. We essentially follow your uterine lining to see if it is prepared or ready for an embryo to implant, and then we place the embryo in the uterus at the right time. So this is what the ovaries look like when we're growing the eggs. So you may recall most of those antral follicles we were looking at earlier were these little tiny circles, and now multiple follicles are growing into larger fluid-filled pockets, and that's where we hope there's an egg. So the process for collecting the eggs is called an egg retrieval. That's a procedure that's done under anesthesia because there is some discomfort with the procedure. It's all performed minimally invasive, meaning there's no incisions or anything that need to heal, and the recovery is very quick. Usually people are able to go back to work the next day, although you will feel that your ovaries are a little bit enlarged and bloated from that process for about a week after the procedure on average. But we perform this procedure using an ultrasound to guide a needle through the top of the vagina directly into the ovary. So the ovaries are enlarged and sitting right next to the vaginal wall. So that's the shortest distance to be able to actually access the ovaries. This is a video that shows what the ovaries look like, and this is a needle poking through into the ovary, and now it's within this follicle, and you'll see this follicle start to collapse as the fluid is drained. So we go through, we puncture the follicle, and we drain that fluid. That fluid collects in a tube, and then we give that tube to our embryologists, which are specialized lab team that works with embryos, and they grow embryos. And so they're looking through this fluid to find eggs. And once we collect the eggs, then we would move on to the next step, which is insemination. And so there's different ways to inseminate an egg or allow an egg to become fertilized. One way is called conventional insemination, where we put just a bunch of sperm in the dish with the egg and allow the sperm to fertilize the egg on its own. Another option is ICSI, which I mentioned earlier, or intracytoplasmic sperm injection, where we actually can collect a sperm. So that's a sperm going into a specialized needle. This is what an egg looks like. We position the egg a certain way and then apply a little suction to hold the egg in place. And then we actually can puncture through this membrane to allow the sperm to fertilize the egg. So you can see the sperm here moving down the needle, and then they'll puncture through that membrane. They aspirate a little bit of fluid from inside the egg to make sure that they're in the right spot, and then you can see the sperm going into the egg. So that's ICSI. This shows what an embryo looks like. So an egg now will then, if it fertilizes, will grow into what's called a 2PN or 2 pronuclei, and you'll start to see that 2 nuclei will form. And then eventually, so this is 2 pronuclei, and then what will happen is all of these cells are going to start to divide into multiple cells because the egg is one cell, and then it will turn into an embryo. So now the whole thing is dividing into 2 cells. This usually happens around day 2 or 3 after the egg is fertilized. And now it will grow into multiple cells. And eventually it will turn into a blastocyst. So this is an 8-cell embryo. Day 2 is when you have a 4-cell embryo. This is a day 1, 2 pronuclei. And this is a blastocyst. So this is the type of embryo that can be implanted in the uterus and that we're able to perform genetic testing on. So this is a blastocyst. There's 2 parts to a blastocyst. These cells on the outside, which are called the trophectoderm, these are the cells that will become the placenta, which provides nutrients to the embryo as it's developing. And this part is the intercell mass, which becomes the actual fetus. So this is going to just show a little bit more of that embryo development. I find this all very fascinating. Hopefully you do as well. Oops, jump ahead. So you can see that the embryo is now dividing up into all of the smaller cells, and eventually will turn into that blastocyst, where you could see it's dividing up into separate layers of cells. These are all, and then there's a big fluid cavity in the middle. And then the embryo hatches. So embryos are contained within this membrane that's called the zona pellucida, which is literally like a shell. And the embryo has to hatch out of that shell, and then it's ready to implant within the uterus. So this is showing, so as I mentioned, there's some hatching where some of the cells will extrude, and that's how we're actually able to perform a biopsy of those cells. So when people do genetic testing, we're actually biopsying and taking some of the cells, usually about 5 or so cells from the portion of the embryo that becomes the placenta. So we're avoiding the part that becomes the fetus, and we're taking cells from the part that becomes the placenta to prevent any impact on the embryo not being able to implant. And these are just, we take the pictures of embryos that are developed and we compare them to the sort of textbook definition of what an embryo should look like. And that helps us to select embryos in addition to the genetics that we perform on the embryos to help select which embryo to transfer into the uterus. So PGTA is that genetic testing, and this has really allowed us to reduce the rates of multiple pregnancies. You may have heard that the fertility field has a reputation of octomoms and things like that, which actually was not IVF. That was associated with that higher order type of pregnancy with lots of implantation. But before we had genetic testing, we didn't know, we were transferring embryos solely based off of the appearance of the embryos. And so as a result, people were transferring multiple embryos because we knew that some of those embryos were likely abnormal and have imbalances in the genetics. And so some are anticipated to work, some are anticipated not to work. And so as a result, if people were transferring multiple embryos and they were healthy embryos, the rates of multiple pregnancies or twins were much higher, and now they are much lower because we are able to select the embryos. And we'll talk a little bit about why we try to avoid twins, even though it may seem convenient to get pregnant with 2 children at once or more. But we'll talk a little bit about why we try to actually avoid that. The genetic testing has also been found to reduce the likelihood of a miscarriage because we're not transferring embryos that are abnormal, and abnormal embryos can implant and stop growing and result in a miscarriage. We also see a reduction in clinical aneuploidies, so things like Down syndrome. Um, but in this circumstance, we do recommend that your OBGYN, once you do get pregnant, will offer you prenatal type testing for these types of conditions and genetics. And we still recommend that you do that because you have to understand the limitations of this genetic testing. It's not a perfect test. And so we do still recommend screening in pregnancy to look for these imbalances. And we're very proud that we do single embryo transfers because that was kind of a concern for a while, and we're still well above the national averages of performing a single embryo transfer. And it's partially because of the advent of doing genetic testing, and we adapted that fairly quickly. So why do we try to avoid multiple pregnancies? They're just higher risk pregnancies for both moms and for babies. And there's higher incidence of issues for babies that are born early, higher incidence of being born early, and then the associated issues along with that. So babies that are born very early go to the NICU and they can have respiratory issues, they can have vision issues, and so the earlier the delivery, the higher risk it is. And there's also risks of stillborn and miscarriages associated with twin pregnancies as well. And so we really try to avoid these things. And the risks are exponentially higher with triplets and beyond that. So we really try to avoid those. So I mentioned we have now collected embryos. We can perform genetic testing on the embryos. Now, when we actually perform the embryo transfer, it's a procedure similar to a pap smear where we place a speculum, we look at the cervix, and then we place a catheter that contains the embryo into the uterus at the right time in the cycle. And the embryo then implants, hopefully. And this is a video of what that process looks like. So this is the bladder, this is the uterus, and you can see this catheter going into the uterus, into the uterine lining, and then it's going to deposit the embryo in the top of the uterus. So similar to not being able to see eggs on an ultrasound, we can't see the embryo either. We can only see the catheter, and we try to place the embryo about a centimeter from the top of the uterus. So this is kind of a profile view of the uterus. So ASRM, which is, kind of going back to the rationale for why we transfer one embryo at a time, we follow the guidelines of ASRM, which is the American Society of Reproductive Medicine, and one of their missions have really been to try and reduce multiple pregnancies, and so they give pretty strict guidelines about recommendations for how many embryos do we transfer into the uterus at any given time. So you can see in most cases with genetically tested or balanced embryos, they recommend transferring one embryo. So this shows you sort of what the expectations are about what is the likelihood of getting a euploid embryo or a genetically balanced embryo. You can see that this correlates with age. And so this is part of the driver for why people do fertility preservation, because you have the option when you're younger to get more of these euploid balanced embryos when you're younger. And so unfortunately, age is a big predictor. And so people who are older in their early 40s, unfortunately, sometimes have to go through the process multiple times in order to get the embryos that they want. And every time somebody goes through the process, we review, this is what we would expect, this is what you have, these are what we would expect the pregnancy rates to be, to kind of walk you through that process. Fertility preservation, I've mentioned that, I plugged that multiple times tonight, but ultimately the options are you can freeze eggs, you can freeze embryos. There's pros and cons to each of those. But we know that the outcomes for frozen embryos are similar to fresh embryos. And that's been well studied at this point. So I wanted to spend a little bit of time speaking about patients who consider third-party reproduction. And in this scenario, we're going to discuss egg donation. But patients who have tried using their own eggs and unfortunately were not able to get pregnant due to age or due to their egg supply being low, or some patients who have gone through early menopause or have done treatments for, cancers. Chemotherapy and radiation can affect eggs. They're very sensitive to those treatments. And so we oftentimes will see patients after they've gone through their treatments, they've survived cancer, and now they want to try and get pregnant. And so unfortunately, we can't grow new eggs in the ovaries at this point. People are working on that, but we're not quite there yet from a technology standpoint. And so egg donation is really the best treatment for these scenarios. Patients who have had multiple attempts with IVF or miscarriages, those patients may consider using donated eggs as well. And then LGBTQ patients, where there's either no egg source, or patients who are single parent by choice, and they don't have an egg source. In those scenarios, people will consider using an egg donor. And we have an egg bank in our clinic, which has been around for many years and has a really high success rate. And so we have, for people who need to consider donor eggs, it's available to them. There's different programs regarding the eggs that they'll discuss with you, if that were something that were recommended. And the success rates of donor eggs at this bank are well above the averages for the country. And so we're very proud of that. So I want to spend a little bit of time talking about PFC, or Pacific Fertility Center, in general. So we really use patient-centered care, and every patient's different. It's not like a one-size-fits-all approach. As I mentioned before, a lot of what we're learning about reasons why people may have trouble getting pregnant is based off of your individual needs and your history and the things about you that make you unique. The treatments may be pretty standard as far as like what the treatments options are, but getting to that point and selecting those and trying other things that may improve natural fertility without fertility treatments are always, a first consideration before we proceed with recommending any of these other treatments. And our clinic has been around for a while now, and so we've had over 10,000 babies that have been born from our clinic. So we're very proud of that. And part of it is because of our involvement in innovation, and we've been very quick to adapt technologies that have really improved the success of the treatments that we can provide, but also cautiously adapting them because safety is a very important consideration. So we vet any new technology that we adapt in our clinic very thoroughly. And this kind of just shows our goals of how we select embryos. We're trying to reduce miscarriage risk because that can be very traumatic, and trying to avoid that, reducing risks in pregnancy by transferring one embryo at a time, and really offering treatments that will shorten the time from when you see me to when you will get pregnant, because most of the patients that I see want to get pregnant yesterday. So my goal is not to delay you by any means, and really just give you all of the information and be your guide. So we have our main clinic is located within San Francisco. We do have an office in Greenbrae and Marin. So I see patients primarily in San Francisco, along with Dr. Ryan and Dr. Lee, and Dr. Agard sees patients in the Marin location. So here's all of our fun things you can follow us. I've been fortunate enough to participate in a lot of the videos, so you probably see me up there. So feel free to follow us, reach out to us, and I'd like to kind of shift towards answering some questions if there are any.
Thank you, Dr. Strug. So we had a couple questions come through.
Mhm.
I have a two-parter here. So um, If a patient isn't having trouble conceiving, but is having recurrent miscarriages, despite all the labs coming back good, so that means hormones, sperm, carrier genes, what would you say your plan of care or an idea of care would look like?
Yeah, so I think what you're mentioning is with recurrent miscarriages, oftentimes patients with recurrent miscarriages don't have infertility, and meaning that like you can get pregnant easily. And unfortunately, the pregnancies are just not healthy, they're not continuing to grow. So, I mean, I can't really speak to your specific scenario because I don't know what testing you've had done, and there's more extensive testing I recommend for patients who have recurrent miscarriages, more extensive than the testing even in patients who have infertility. But again, everybody has specific variables or factors that I'm considering. But the prognosis for recurrent pregnancy loss is ultimately very good. It unfortunately requires people to keep trying, but there are different reasons why people will have miscarriages. And so my first approach is to try and better understand what underlying contributors could be causing miscarriage, but we do know about half of the time we might not find a reason, and then at that point, we have to talk about what the options would be at that point. But yeah, so unfortunately, we could have a whole presentation just on recurrent pregnancy loss and recurrent miscarriage because there's a lot of known information, but there's also a lot of unknowns. And so it's really just spending a lot of time going through all of these different considerations and things that we might want to use to guide treatments that are available to you.
Okay, and I think you answered the second part of that question, which was if IVF is something you can't do, what other things could you offer for someone having multiple miscarriages?
Yeah, so it really ultimately depends on the person. So if there's health conditions that may coexist, sometimes we work to try and optimize those. If there are specific um, considerations as far as age. Sometimes we do recommend IVF for screening embryos because some people have recurrent losses due to aneuploidy or, the embryos are imbalanced in the genetics. And so in that scenario, maybe we do recommend IVF. But in other cases, then the options really are to keep trying. Sometimes we'll add additional agents like progesterone, aspirin. There's pros and cons to some of these other treatments. There are some other treatments we consider like immune type treatments. So there are things out there, but we kind of have to, weigh the pros and cons, what data is available, and also, what are your individual factors that may make you benefit from one over the other.
Okay, and we'll just give another couple minutes for a couple questions. Again, the Q&A feature is at the bottom of the toolbar in Zoom. So feel free to ask anything. It doesn't have to be about IVF. If you're curious about other treatments, that sort of thing, do feel welcome to ask any questions.
So we have another question about, commonly people ask this question about, if you're doing IVF or doing these treatments, does it put you through menopause earlier? So we have to think back to remember when we were discussing the antral follicle count. When we're doing IVF, we're actually growing the eggs that would otherwise not, would disintegrate and not continue to grow that month. So we're actually taking advantage of this pool of eggs that are available that month where only one would typically grow, and we're growing hopefully a large proportion of those eggs to try and get multiple to grow. And they've done studies to look at, do people who have done IVF or egg freezing go through menopause earlier or things like that. And we don't see that there's any association between those things. So hopefully that provides a little bit of reassurance about when people go through the process that we're not damaging your future fertility. And okay, let's see.
Okay, so I have one here. What is the general timeline for both IVF treatments and IUI?
Oh, good question. So for IUI, it's usually each cycle is a treatment month. So you're taking pills in the beginning of your cycle. Then we perform an ultrasound towards the middle of the cycle to look to see our eggs growing, and then also look at the uterine lining. And then we time the insemination usually 1 to 2 days after ovulation is expected. And then you check a pregnancy test in 2 weeks. So that ends up being about, a typical 4-week cycle. For patients doing IVF, it can be about 1 to 2 months because some people will take medications before the month that they actually start growing eggs to prime the ovaries or prepare them to better respond. And so in that scenario, you're checking oftentimes ovulation type kits and then starting a medication in the week or so leading up to when you would expect a period. Then with your period, we do an ultrasound and at that point decide, are things looking ready to start the injections and start the treatments. Those injections you start and usually do them for about 9 to 12 days on average. The egg retrieval procedure is about 2 days after the last day of your injections. So that ends up being about 2 weeks actively where you're doing the treatments. And then the recovery is about a week after that, but there's no visits or treatments that you're doing beyond just, allowing your body to heal. It takes about 3 to 4 weeks to get the results back on the genetic testing when you do that. So most people will take a month in between when they do their IVF and then do an actual embryo transfer in the month after that. So it can take 3 months to do IVF from start to finish, from growing the eggs to checking a pregnancy test after an embryo transfer. It can be 3 to 4 months. If you're doing the priming, then it would be closer to 4 months. So it can be a longer process for sure.
Yeah, so let's see here. During the IUI or IVF treatments, um, how much time, when you work with patients, Dr. Strug, how much time should patients take off for work?
Yeah. So we're very flexible. We have appointments as early as like 7:30 in the morning for people who want to try to make appointments for ultrasounds and things like that for your treatments during, you know, a work week. We're open every day. So even on holidays, I like to say that we work on the ovarian calendar and not on, the typical lunar calendar, because really we have to be available when the ovaries say it's time to collect eggs, it's time to ovulate. All of those things are really oftentimes out of our control. And so we are, kind of going based off of those things. And so we try to be flexible for our patients. We're here every day. As I said, we're not here on holidays, or sorry, we're here on holidays. We don't close on holidays. So we're able to be there for our patients. But most visits for ultrasounds are about like 30 minutes or so. And we're always happy to provide like a work note and restrictions and things like that when necessary. But it depends really on the treatments. But usually IUI, you're doing one visit for the ultrasound, 1 to 2 visits for ultrasound, and then you're doing one visit for the IUI. So it ends up being about 2 to 3 visits within your cycle that you're here. And then IVF is a little bit more visits. You need about five or so, 5 to 6, and that includes doing the egg retrieval procedure. So that's all within that span of the time frame I was discussing earlier.
Okay, and it looks like there was a second part of that question. Um, I'm not sure what this term means. For TIC, 1 year of treatments, what would you generally recommend the next steps for PCOS?
So if you've done timed intercourse, I'm presuming maybe you've done medications with that to try and induce ovulation. That would be the first step would be if you have PCOS, you're not ovulating predictably, then in that scenario, we want to give a medication. Usually letrozole is the medication of choice for patients who have PCOS because the studies have shown that the pregnancy rates are a little bit higher than using some alternative medications. And so if you've been doing that for about a year, then at that point I would suggest it's time to move on to IVF because as I said earlier, we see that the benefits sort of plateau at around 6 months of trying. You could consider adding inseminations on. You're saying that you're doing timed intercourse, so depending on what the sperm counts have looked like, if they're borderline low, maybe an insemination might improve things because we're putting more sperm closer to the egg. But if the sperm counts have been very high or normal, then the insemination's not necessarily going to be adding much benefit. And at that point, maybe IVF makes the most sense.
Okay, and as we wrap up here, someone asked, for someone who has fibroids, what would typically be the better treatment, IUI or IVF?
So I wouldn't recommend one or the other specifically due to fibroids. If fibroids are most relevant when they are located within the uterine cavity, which is where the embryo would need to implant. And so they provide sometimes a less favorable environment for the embryo to implant and have been associated with infertility and also with slightly higher risk for miscarriage or early pregnancy loss. And so the treatment in that scenario would really be first by removing the fibroids if they're within the uterine cavity. There's also some data that large fibroids, so fibroids over 4 centimeters that are located outside of the uterine cavity, may impact fertility, and surgery may be recommended in that scenario. But I'd really want to know sort of what are the other conditions in regard to the sperm and the eggs and age and ovulation, all the things that I mentioned before I can really make a recommendation regarding IUI versus IVF. There's pros and cons to both options. So fibroids don't sway me either way to recommend one versus the other, but I would really want to know where the fibroids are located, the size of the fibroids, are they impacting the uterine cavity? It's possible that maybe just doing surgery would be enough if it was distinctly within the uterine cavity that may improve pregnancy rates even without doing IUI or IVF. So it ultimately depends on all of those variables. And that's why we do, as I said earlier, a really comprehensive evaluation up front because we don't want to go down the road of saying, oh, it's just a fibroid issue when maybe the sperm counts were low or maybe there's other ovarian considerations.
All right, thank you, Dr. Strug. So we're going to wrap up tonight. We just want to thank everyone for being here tonight, and we hope you found the presentation helpful. So we'll be sending out a recording of the webinar tomorrow morning. If you have any follow-up questions, please feel free to respond to the email or call our clinic at 415-834-3095. Again, thank you for joining us tonight. Thank you for your time, Dr. Strug, and we hope everyone has a lovely evening.
Thank you, everyone. Have a good night.
Yeah, take care. Bye-bye.